We will start the program now. So, respected chairperson, Dr. Adhigamiti Madam, the registrar, we are OSR University of Health Sciences. Madam is also the president of the IPS Vijayawada chapter. Today we have an excellent speaker, Dr. PRADEEP Palniyappan, professor and Department of Psychiatry, PhD Institute of Medical Science and Research, Coimbatore. And today we have a moderator, Dr. Aswath Babu. Dr. Aswath Babu is a consultant psychiatrist of our Snega Mindcare Hospital, Tirunelveli. My dear colleagues, rating psychiatrists and dear postgraduates, very good morning to all of you. Indeed, it's a great privilege for us to meet to organize this Evolve webinar. And I welcome you all for this webinar in this morning, Sunday morning. My profound thanks to Dr. Adhigamiti Madam. Madam was very busy in spite of our busy schedule. Madam has accepted to chair our program. Today we have conducted this Evolve webinar almost for a year. This is our 10th program, and we are conducting this webinar on every 4th Sunday. So there is a overwhelming response from across India. Many postgraduates from southern as well as the north state, they're joining our programs. So we also choose the topic which is very relevant to the postgraduates, and it is indeed refreshing for the practicing psychiatrists also. Today we have a very eminent speaker, Dr. PRADEEP. Dr. PRADEEP is a son of our senior most psychiatrist, our Tamil Nadu IPS, Dr. V.C. Palniyappan sir. PRADEEP today is going to speak about autoimmune encephalitis and psychosis and ambiguous. Hope this topic will definitely be useful for the postgraduates as well as the practicing psychiatrist. With a small introduction, I request Dr. Aswath, a moderator, to take over this session. Yes, Dr. Aswath.
Yes, sir. Good morning, sir. Good morning. Very good morning to all the respected seniors and dear juniors present here. Myself, Dr. Aswath Babu, currently working as additional consultant psychiatrist at Snega Mindcare Hospital, Tirunelveli. I will be the moderator for today's session. Special thanks to our Evolve course director, Dr. Panneerselvam sir, for giving me this. Dr. V. Radhika Reddy ma'am has done her MBBS in 1991 and her MD in Psychiatry in 1997, both from Sri Venkateshwara Medical College, Tirupati, Andhra Pradesh. Madam is also Andhra Pradesh State Representative to IPS South Zone currently. In the past, she has held positions such as Joint Director, Directorate of Medical Education, Vijayawada, Andhra Pradesh during 2022 and 23. Professor and HOD, Government Siddhartha Medical College, Vijayawada, Andhra Pradesh during 2011 to 2022. She has held various positions of Women Empowerment Committee in state, zonal, and also in the national level. Madam has done many awareness programs in both print and electronic media. Ma'am, we are privileged to have you as chairperson today. Now, I request you to introduce the topic and today's speaker, ma'am. Thank you.
Thank you, Doctor, for giving me this opportunity, first of all. And Dr. Panneerselvam and Dr. Aswath, Dr. PRADEEP, and all the seniors over here, and all my the loving postgraduate students who are attending this webinar. So it's my privilege also to be here with you all, and I thank you very much for giving me this opportunity to meet all the postgraduates and also the eminent people. And the topic chosen today, the autoimmune encephalitis itself, is a current in current scenario. It's a very difficult topic as such, because we never think about it while diagnosing the first episode psychosis. So we always think it's a primary schizophrenia and then start our treatment. And as such, investigations in a psychiatric consultation chamber are usually, we don't really do many of the investigations. We are more based on the clinical picture. Today, our speaker will be enlightening us on all these things, the diagnostic approach to the first episode psychosis, and also the therapeutic considerations. And I love to introduce the speaker today to this Evolve program, Dr. PRADEEP. Dr. PRADEEP is currently Professor of Psychiatry at the PSG Institute of Medical Sciences and Research at Coimbatore. So he did his MD from Enhance, Bangalore in 2006. And with all of around 15 years of teaching experience, at present he is working as Professor of Psychiatry. He has many awards in his back, definitely. But the most prestigious project under him at present. So he was awarded the national and the national level competitive grant for this under which the program is running is the Department of Science and Technology Cognitive Science Research Initiative for gaming. Actually, this is again a very important subject, like design and development of AI-powered cognitive remediation therapy through gaming in schizophrenia subjects. So Pradeep is very much interested in schizophrenia and the way the therapeutic approaches for schizophrenia. So that's the reason he has selected this topic also, the autoimmune. In this brief introduction, I would like to call upon Dr. Pradeep to enlighten us with the topic and in depth. And so, Pradeep, now the stage is for you. Yeah.
Hi. Thank you. So good afternoon all. I think it is my privilege to thank the organizers, Dr. Panniyaselvam sir, the moderator Ashwath, who has been coordinating behind this program. And I heard about this Evolve program from my own PGs in my institute. So it looks like a lot. The reach of this seminar is also very good all throughout the India. So nice to know about the progress of this seminar as well. I chose this topic in view of we do see this presentation where first episode psychosis, as ma'am have said, very frequently we do see a lot, being a general hospital setting is where we are working. We do have a close liaison with the neurologists. We have the advantage of having that, and many times the autoimmune encephalitis is one of the reason pops up now and then. So with that in mind, I thought it will be a good introduction for the young budding PGs, and thus they will carry on with further reading. It may motivate them to read more on this, and then probably the understanding about this will probably shape the way we look at the psychosis, and it may evolve into a much better technologies in the future to treat psychosis as well. So with this, I thought this webinar with Case Vignet, which has been published in 2017. So this case report actually talks about an 11-year-old girl who presented to a psychiatry outpatient department with a history of abrupt change in behavior, deteriorating over a period of around 3 weeks. She initially presented with a lot of crying spells, saying her left hand was not working and dragging her left foot while walking. After 2 to 3 days, she reported of nihilistic ideas that her hands were cut and they were useless. There were episodes when she would try to run out of the room as a person. Yeah. So she would also bite her fingers and sometimes the cheek mucosa as well. So after around a week of onset of these symptoms, she became more fearful that the ghost was coming after her and was trying to harm her. Her sleep and appetite was decreased. Her self-care was very much impaired in this last 2 weeks. Started developing catatonic symptoms like staring, mutism, and withdrawal, impulsivity, and perseveration. She also started developing dyskinetic movements of the left hand and of the orofacial region. The MR imaging, magnetic resonance imaging, showed a normal study of the brain parenchyma and no abnormality was detected in the EEG as well. So until now looks like a person who has psychotic symptoms, probably shifting in presentation every day. New symptoms are getting added with some dyskinetic movements of the left hand. So until now, it is an usual psychosis. There were no focal neurological deficits on a good neurological examination, and thus a provisional diagnosis of acute transient psychotic disorder was made. But what was more vivid or clear is that the dyskinetic movements of the left hand, which resulted probably in a consultation with the neurologist, and neurologist probably after reviewing the MRI and EEG thought about a CSF analysis of NMDA receptor antibody. So both a serum sample and a CSF sample was suggested. On the CSF analysis, that which was analyzed using an indirect immunofluorescence, it was positive in 1:10 titer. CSF examination also showed pleocytosis, a protein count of protein of 20 milligram per deciliter, a sugar of 68 milligram per deciliter, and the CSF culture and sensitivity for all other infections were sterile. So CSF NMDA also came up to be positive. So this is where a routine presentation of an acute transient psychotic disorder gradually moved on into an autoimmune encephalitis. Why are we talking about an autoimmune encephalitis? Why it should be actually proactively thought about? What happens if at all we miss the diagnosis, or we miss to even suspect about that possibility? What happens if it is detected late, and what is a prognosis if not treated? So these are all the thoughts which we should be having when a person has acute transient psychosis with some atypicalities, right? So the most of the literature which have come up have been predominantly published in neurology journals more than the psychiatry journals. So where neurologists come to see neurological symptoms with some behavioral symptoms. So what is often seen in these presentations is that they sometimes get hospitalized in psychiatry departments before being transferred to a neurology ward. So many times it is highly possible that the neurologists say that they may go misdiagnosed as a primary psychiatric disease. So they also say that any delay in diagnosis of an autoimmune encephalitis, it increases the cost and the morbidity. And they also report that at least 70 to 80% of patients recover if the immunotherapy is initiated, a prolonged ICU stay, and sometimes it may even go to the level of mechanical ventilation. So such is the importance that it is attached to the autoimmune processes attached to the psychotic symptoms. But at the same time, not all people who have a serum antibody are diagnosed to have autoimmune encephalitis. So what I'm suggesting is that even in patients with schizophrenia, bipolar, and even depression, there are case reports of serum positivity of anti-neuronal surface antibodies. So it sometimes could be incidental, but sometimes may be the cause of the current presentation itself. So just the presence of an serum antibody does not mean that it is an autoimmune encephalitis, is what is the saying goes on. So what is actually an autoimmune psychosis? So as of now, the current ICD-10 or 11 or DSM-5 doesn't have any diagnostic criteria which has been validated in field studies. So most of these criteria are based on expert panel and people who have been working in this group and who have come up with a consensus on what could be the diagnostic criteria for an autoimmune psychosis. So the thought about a possibility of an autoimmune psychosis is there if there is an abrupt onset of psychotic symptoms with at least one of the following, like any tumor. For example, an ovarian teratoma. So where a psychosis is more of a paraneoplastic presentation of the tumor by itself. Or when the psychosis co-occurs with some movement disorder like catatonia or dyskinesia. Or when there is a psychosis with an adverse response to an antipsychotic. So people are more sensitive to EPS for second generation antipsychotics, or they have landed in neuroleptic malignant syndrome with the doses which we don't usually expect them, then you think about a possibility of an autoimmune psychosis. Or if there is a severe cognitive dysfunction, which is disproportionate to the amount of psychotic symptoms, or there are now and then interspersed with delirium, then also you think about a possibility of autoimmune psychosis, or a new onset seizures, or a significant autonomic dysfunction, like a very fluctuating blood pressure, temperature, or heart rate. When psychotic symptoms happen with this one or the other, then the possibility has to be thought about. You can think of, if at all there, then you need certain investigations to really say whether it is more probable. Important criteria which they should possibly meet is the CSF analysis. So two things could be thought about: one, an MRI or a lumbar puncture and a CSF analysis. So CSF pleocytosis with more than 5 per millimeter cube, or a T2 FLAR sequence which have bilateral medial temporal hyperintensities. T2 weighted one, if hyperintensities are there, then this should be more likely that it is more probable. Or if there is EEG alterations, that is suggestive of an encephalopathic EEG alterations, which I will also talk about in the later part of the slide, or CSF specific oligoclonal glands, or a presence of a serum anti-neuronal antibody detected by cell-based assay. So if I want to press again, this presence of a serum anti-neuronal antibody by itself is not a diagnostic of an autoimmune psychosis. So for a definitive diagnosis, including all the above possible and probable criteria, there should be an evidence of an IgG anti-neuronal antibodies detected in the CSF. If this is there, then it is a definite autoimmune psychosis. So this is the current consensus of how you diagnose an autoimmune psychosis. So most of the thing which I'm going to talk about is autoimmune psychosis pertaining to the anti-neuronal antibodies. Autoimmune psychosis is a much more broader term, which also involves, let's say, psychosis due to Hashimoto's thyroiditis. It can be due to an SLE. It could be due to various other causes as well. But I am not going to present anything about those disorders. I'm going to present exclusively about the autoimmune psychosis caused by the anti-neuronal. So I will again now focus on what is this neuronal surface antigens. I will spend few time in these slides so that we understand what are these antigens and why these antibodies have been there. So I will give little abbreviations of many of the things we may be familiar about, like NMDAR. It is a glutamate receptor, while leucine-rich glioma inactivated protein, and Casper, that is contactin-associated protein, and voltage-gated potassium channel complex. Similarly, AMPA is basically another glutamate receptor. There are GABA B receptor and DPPX. I will give you an idea of what is these. So before I move on to this slide, I will show this diagram. This is a GABAergic neuron, and this is a glutamatergic presynaptic neuron. And we have a postsynaptic GABAergic neuron and postsynaptic glutamatergic neuron, right? So in the GABAergic neuron, so this is a GABA A receptor, and this is a GABA B, which is a G protein coupled receptor, which influences a potassium channel. So this is a part of the GABA postsynaptic in antigens, right? So in the glutamatergic neuron, in the presynaptic way, there are two proteins which are associated with this potassium channel. So this is a voltage-gated potassium channel. So, VGKC, if you would have heard commonly, is this channel, which is a presynaptic channel. So it has two proteins. The blue color one is the Casper protein, while the gray color one is the contactin 2 protein. So these two proteins also influences the VGKC. Similarly, VGKC is also influenced by another few proteins which connect the presynapse and the postsynaptic neuron. These are ADAM proteins which are on the either end, and this is the LGI1 protein which connects all these. So if you carefully look out, this is a big complex of VGKC complex. Right, so this should be kept in mind. This is an AMPA receptor, glutamate postsynaptic receptor, and this is an NMDA postsynaptic receptor. So with this in mind, I will again come to this slide. So antibodies that bind to all these type of thing are called as neuronal surface antibodies. This can be an antibody to an intracellular antigen, which are present within the postsynaptic neuron, like WHO antigen, GAD antigen, or MAR2. Or it could be a cell surface against the cell surface receptors. We saw that NMDA, AMPA, GABA, A, B, and glutamate R5, dopamine 2 are cell surface receptors on the postsynapse, synaptic neuron. Or it could be against the ion channels, like as we discuss about the VGKC, that is voltage gated potassium channel, which have LGI and Caspar2, or it could be DPPX and aquaporin type of ion channels. So antibodies against all this are collectively called as neuronal surface antibodies. So if you can look out, autoimmune encephalitis, though it is an umbrella term, the presentation differs based on antibodies which are specific to each surface receptor or ion channel. So the presentation differs, their neurological presentation, psychiatric presentation differs, and also the treatment differs based on against what NSA the antibodies are developed. Okay. So I will first focus on something called as NMDAR antibody encephalitis, which is the most common type of encephalitis, where it is about against the NMDA receptor, a glutamate receptor. Multiple articles are published. Very interestingly, it all started with one of these early publications, which have actually reported prominent psychiatric symptoms in 12 women. The women presented with seizures, a lot of cognitive symptoms like memory, amnesia, frequent dyskinesias, and autonomic dysfunction, and delirium, often requiring ventilatory support. And on investigation, they were found to have an ovarian teratoma as well. So 80% of the adults present, especially NMDAR encephalitis, presents with psychiatric or behavioral symptoms. So most probably they may land with psychiatrists initially rather than the neurologists. So these symptoms include vague symptoms like anxiety, agitation, bizarre behavior, catatonia, delusional symptoms, visual and auditory hallucinations accompanied by cognitive dysfunction, especially memory loss. Sometimes it need not be a complete syndrome. A partial or an attenuated syndrome is also often presented, where there will be a predominance of psychotic symptoms, but other classical characteristics of NMDAR may not be there as well. Okay, so that is very, very rare. They presented with the isolated psychiatric symptoms. In the reason, what they are trying to say is 96% of the time, the NMDAR antibody encephalitis has predominant psychiatric symptoms, but also neurological symptoms. So 96% of the time, the neurological symptoms will be there along with psychiatric symptoms. So when this combination happens, I think we should always think about an autoimmune encephalitis. So many of the time, they may present with 74% with delusional thoughts. More than the hallucinations, delusions are more common. Maybe also a mood like mania, mood lability, disinhibition, depressive symptoms are also common in NMDA encephalitis. majority have a persistent subjective cognitive dysfunction, especially memory disturbances. So this is one of the classical T2 flare MRI. So this brain section basically says a demyelination in the frontal area, right frontal abnormality, which is one of the classical thing of a NMDAR encephalitis. The other thing which are very, very important for NMDAR encephalitis is the EEG. There are a lot of EEG changes which can happen in any encephalopathy, but extremely important form is called as an extreme delta brush, which is a very classical thing of a NMDAR encephalitis, where there will be a delta activity and a sudden frequency changes to the beta activity. So if you can see, it almost looks like a brush. So this is what they call as a extreme delta brush. So this is one of the common thing of a NMDAR encephalitis. To our surprise, most of the time the MRI will be normal. So only 1/3 of the time it is basically abnormalities will be seen. So 2/3 of the time MRI will be normal in NMDAR. So even in the patients whom we have seen in our hospital as well, there were multiple times when the baseline MRI and the follow-up MRI were both normal. But yet it was CSF positivity for NMDA antibody was there. So it may not be there in all people. So an extreme level of high index of suspicion may be required to investigate in the CSF analysis as well. So it need not be in the frontal white matter alone. It could be in hippocampus, cerebellar, cerebral cortex, fronto-basal, and sometimes insular cortex as well. The CSF typically basically shows a moderate pleocytosis with increased total protein and oligoclonal glands, which are there in 79% of the time. So the diagnostic criteria or how NMDA usually presents is the diagnosis is based on at least 3 of the following criteria. So a rapid onset, less than 3 months of all this 4 out of 6 group of symptoms should be there. 1, there should be an abnormal or psychiatric behavior or cognitive dysfunction, a speech dysfunction like mutism or a pressured speech or a verbal reduction or a new onset seizures or a movement disorder or a dyskinesia or rigidity or a delirium fluctuating level of consciousness or an autonomic dysfunction. So among these 6, 4 should be there for a probable anti-NMDA receptor encephalitis. And along with it, any one of the abnormal EEG, as I said, as delta brush or CSF showing pleocytosis should be there for a diagnosis of an NMDA encephalitis, and reasonable exclusion of other disorders like infection as the cause or other hormone in the sense like an endocrine causes, all other causes should be ruled out. So sometimes if there is a ovarian teratoma, then in the it is a common diagnosis which is made. Then the diagnosis of an NMDA encephalitis becomes much more easier. But a definite diagnosis, if at all there, has to be basically based on a CSF IgG anti-GLU N1 antibodies. So anti-GLU N1 is nothing but the NMDA basically has multiple subunits, N1, N2, N3 subunits. So for a diagnosis, we need IgG, not an IgM. So IgG says that there is a current inflammation, which should be an anti-GLU against the N1 subunit of the NMDA receptor. If it is there, then a definite diagnosis of NMDA encephalitis is done. So I will come to the other common thing presentation, which is basically VGKC, limbic encephalitis and psychosis. So this is also very common, the interest in which came during the early papers of 2001. So it's almost for 20 years, we know that this has been presenting in this way. So this VGKC, when it was detected and a plasma exchange was done, it was effective in reducing the antibody trial levels, along with substantial improvement in mental symptoms when this plasmapheresis was carried out. So in VGKC antibodies, there are different types. There may be a peripheral type or a central type. So the peripheral type is the classical is the Marfan syndrome. So Marfan syndrome is where they will have a peripheral nerve excitability. So many times we would have seen a VGKC antibody, serum antibody in people who have been on neurotoxic drugs. So sometimes the metals like arsenic, which are used in some of the other alternate medicines, has been one of the common cause for VGKC antibodies. So which results in a lot of myotonia, myokymia, and other peripheral nerve fasciculations. All those are well known when it is exposure to when alternate medicines are being there, especially metals. So that is a peripheral presentation of the VGKC antibodies. So Marfan syndrome, whereas a central basically causes limbic encephalitis, where it presents with memory deficits, delirium, and medial temporal lobe seizures. The psychiatric symptoms, commonly it presents with the personality change, mood symptoms. Then the psychotic symptoms are less frequent in VGKC antibodies, but it is also common that they may have both mood symptoms and psychotic symptoms at the same time. Predominantly, if at all there, it is more like a schizophreniform or a polymorphic psychosis with varying degree of cognitive deficit. Many times, this is the central VGKC antibodies, encephalitis, are being diagnosed initially as primary psychotic illness. Only they are discovered after and incidentally has been found to have a hyponatremia, or sometimes when they have seizures during a primary psychotic illness. So most of the VGKC antibodies are directed towards this LGI1 and contactin protein. So LGI1 antibodies predominantly present with limbic encephalitis or an epilepsy, sometimes without even tumors. Whereas predominantly antibodies to the Casper protein presents within limbic encephalitis, often with a tumor like thymoma. So there are even the antibodies against each of these protein, the presentation actually differs. So the diagnostic criteria for a definite autoimmune limbic encephalitis is a subacute onset of these working memory deficits, seizures. In most of the people, there will be a bilateral T2 weighted flare sequence suggestive of hyperintensity in the bilateral medial temporal lobes, and at least one of the following, that is CSF pleocytosis and EEG, predominantly involving the temporal lobes. In VGKC autoimmune encephalitis, sometimes if the MRI is normal, if there is a high degree of suspicion, the FDG PET is often done to understand the hypermetabolism in these association cortices, which are picked up much better with the FDG PET when compared to an MRI. So if there is a high degree of suspicion, people again do an FDG PET after an MRI negative finding as well. So this is the classical of a bilateral temporal lobe limbic encephalitis, whereas the picture on the right has unilateral temporal lobe hyperintensity, which are not actually the case of a typical limbic encephalitis. So this is the FDG PET, which have shown hypermetabolism in the association cortices. As you see, the blue basically says the uptake is less. The red basically shows that the uptake is more, suggesting there are hypermetabolic, whereas more towards the blue is hypometabolic. So if you classically see the baseline pictures, many of the association cortices are all hypermetabolic, whereas the inner primary cortices are predominantly hypometabolic, which actually reverses during the follow-up PET scans with immunotherapy. So I have given idea about two important autoimmune encephalitis. I will briefly go about the presentation about other antigens and and their presentations. This we have actually spoken about in well detail. An ovarian teratoma is often there in women. So many of the time it is an asymptomatic teratoma. In fact, in our hospital experiences as well, in fact, a proactive CT pelvis as basically we were able to find out an ovarian teratoma which was asymptomatic for a long time. Regarding the VGKC LGI1, hyponatremia is a common presentation. A thymoma or a neuroectodermal tumor may be there, but many of the times it is a hyponatremia, which will be a classical presentation. Whereas in CASP2 it will be predominantly peripheral muscles. So neuromyotonia, Morvan syndrome will be there. But if it is central, many times there may be a thymoma. There are other things like glycine receptor, AMPA, which is basically a glutamate receptor, which also presents with lot of cognitive dysfunction and psychosis. Similarly, the dopamine D2 receptor, it presents in autoimmune encephalitis in pediatric age, where they present with movement disorders like Parkinson's, chorea, dystonia. So MRI predominantly basal ganglia will have hyperintensities when compared to the frontal or other gray matter. So if in that case, when to suspect autoimmune psychosis, there are various things, if at all is there in our first episode, psychosis, always think about an autoimmune etiology. The atypical presentations are basically an atypical age of onset. We know that most of the time the age of onset is around the young adults are basically the common age for presentation of schizophrenia. But the atypical age of onset or the psychosis presenting with a lot of disorientation, misidentification of place, time, person, or language disintegration, then you should also think about this as a cause. A catatonia, that could be, or predominance of visual and multimodal hallucinations, or an olfactory hallucinations, especially of the temporal lobe pathology. Many times this can be a presentation. Or predominance of misidentification type of delusions like Capgras, or antecedent medical illness, or a concurrent medical illness, or systemic in manifestations. So many times people may present with psychotic symptoms after a brief febrile illness, which we usually say is viral flu. And if that is there, another area you have to think about as an atypical autoimmune encephalitis could be the cause. Or any other lack of predisposing risk factors, like lack of strong family history, lack of schizoid personality, or any precipitating stress, sudden onset of psychotic symptoms, then also you should think about autoimmune as a possibility. Or presentations along with neurological disturbances like encephalopathy, seizures, movements, autonomic instability, or delirium. As I said, certain soft overt signs of non-neurological examination and a strong past or a family history of autoimmunity. If all this is there, then probably we need to think about autoimmune as a possibility. So these are all the red flags which, if present during our examination, it should always raise the bell, and it should definitely, we should look for an autoimmune etiology. So the typical signs are basically, as I said before, acute or sometimes subacute presentation without any predisposing factors. But if there are other things like Crohn's, psoriasis, or primary biliary cirrhosis, all these are all possibility of an autoimmune psychosis, right? If there is a typical clinical findings like polymorphic psychiatric symptoms, presence of catatonia, presence of speech, seizures, any new focal neurological deficits, autonomic instability, comorbid tumor diseases, and unexplainable headache. So these are all the common symptoms. If it is there, it should be a red flag. Similarly, if the course of the presentation, if it is rapidly progressing despite your treatment in accordance with the guidelines. So antipsychotics, they are not improving, they're rapidly worsening. Then also you should think about this. Or antipsychotic intolerance, even they are highly sensitive to extrapyramidal side effects, even with second generation antipsychotics. Then you should always think about an autoimmune encephalitis. Or other findings like an unexplainable sudden hyponatremia or CSF pleocytosis, EEG alterations, and MRI some pathology or FDG PET alterations. So any of these are basically all said to be the red flags. If at all there, we should definitely think. So if at all there, how to test? I'm not going to the entire the procedures, but I will give you an idea what type of assays are there. So it should not happen that the neurologist says something and we are totally taken aback by their technical terms. So to understand that, there are three types of assays. The most common screening assay is this assay, which is a fixed cell-based assays. So it is usually called a CBA. So there are CBA for multiple antibodies. So it is very specific where there are transfected HeLa cells are there, where when the serum or the CSF is basically added to this, the HeLa cells which has the NMDA antigen on it, if there are NMDAR antibodies in the serum or CSF, it gets binded to that antigen, and as a result of which the staining becomes more red. So that is how each antibody are evaluated. So this is a screening test, but it is not a confirmatory test. There are other tests, basically an immunohistochemistry of the rat brain slices. So there is an autoimmune encephalitis protocol is there. So if you can see there, there are a lot of staining of the hippocampus with anti-NMDA positive patients serum. So this is much more confirmatory. But the more important thing is the live staining. So this is a live staining of the cultured rat hippocampal neurons using an anti-NMDAR positive patient serum. So here, if you can see, there are punctate green staining over the dendrites, which is not there in a controlled serum. So this classically suggests that this person is probably an NMDAR positive. So what is the mechanism behind this one? So we know that NMDAR antagonist, they mimic the positive and negative symptoms of schizophrenia. This is the animal models which have been there. NMDA are hypofunction model of psychosis. So a down regulation in view of NMDAR antagonism, it is proposed that other neurons like GABAergic neurons, other starts to gets down regulated, and the pyramidal dendritic dysgenesis happen and a reduced spine density happens. So NMDARs are reduced in unmedicated schizophrenia also. So this supports that NMDAR hypofunction is a possibility out of these things. So this is the normal neuron, a pre-neuron and a postsynaptic neuron. So if there are antibodies which are there all around, it results in clubbing to these postsynaptic receptors, and it causes internalization of these receptors, as a result of which, even if there are a lot of glutamate which is released from the presynaptic neuron, there are less number of postsynaptic neuron to act. As a result, secondary other things also come down, regulation of other GABA and other systems also happen. So there are multiple things they have proposed the reason for all this autoimmune encephalitis. So one is possibly the antigen thing, where when these antibodies attach to the surface proteins, it results in a modulation of the surface protein by itself. As a result, some subunit of that receptor sometimes gets expressed when it should not be expressed. So suddenly the body recognizes this as an alien subunit which is expressing outside the surface membrane, and antibody is produced. Or there may be a loss of protein interaction. So these antibodies can come and probably be combined with these subunits, as a result of which protein interaction may not happen. As a result, loss of functioning could be possibility. The other possibility is they would have actually activated the complement factors, as a result of which the complement activation results in probably non-functioning surface receptors and ion channels, and it may actually induce the MAC mechanism and further internalization of these receptors. Or it could have been also resulted of basically it is cell-mediated cytotoxicity. So this may actually stimulate the microglia in the brain, as a result of which these receptors could be cleared. So, or it is an activation blockade. So there are multiple mechanisms how these antibodies really causes these symptoms. So VGKC autoantibodies also has been noted to have a lot of cellular infiltration and immunoglobulin deposition and complement activation. Whereas NMDAR encephalitis, so much of inflammation is not seen. So VGKC is more related to complement activation and this deposition. NMDAR is not so much. So specific in this context, one specific autosomally dominant genetic disorder has been also shown, where a mutation in the LGA gene can result in auditory hallucinations and partial epilepsy as well. The other possibility which they think is about a molecular mimicry. So based on this, we all know that there is a maternal cytomegalovirus infection and a genetic polymorphism in these. So maternal infection in development or an infection during childhood could provide an antigen for molecular mimicry. And it may, the antigen may resemble like that of an NMDA receptor. So when the antibody probably is produced for this antigen, it also affects our normal antibody receptors as well. So this could be another possibility of why this is resulting in psychotic symptoms in vulnerable population. If that is the case, how to treat? Really, the literature is very less. There are no RCTs. There are predominantly case reports, and it is all case reports and case series and expert consensus, which is what I'm going to present today. So as of now, people prefer a second generation antipsychotics when compared to the first generation antipsychotics like haloperidol, in view of propensity of first generation antipsychotics to cause extrapyramidal symptoms. So many times a second generation antipsychotic like olanzapine, clozapine probably may be more preferable when compared to the first generation antipsychotics. But if there are severe agitation, let's say there is delirium, aggression, then a more sedating atypical or a judicious use of typical antipsychotics along with anticholinergics has been suggested by some authors. But the risk of neuroleptic malignant syndrome is very high, and it is high possibility that it can have a symptom overlap with the encephalitis symptoms as well. So some of the, especially in NMDA receptor antagonist toxicity, it is proposed that clozapine-like antipsychotics may prevent these toxicity as well because of its less anti-glutamate activity. There are also reports of using clopramazine, aripiprazole, risperidone, ziprasidone, and sometimes even midazolam for severe agitation. But these are all case reports. We don't know what may be the best agent. But if mood symptoms are there, lithium and valproic acid also has been used to improve the manic symptoms. Many times, benzodiazepines, especially lorazepam, a short-acting benzodiazepine is used for sleep, and sometimes trazodone, melatonin, clonidine, or other things are used for the sleep as well. ECTs have been also tried for improvement in psychotic and catatonic symptoms when they don't show a good response to other treatment options. But this ECT is only advised after a thorough medical workup, ruling out other contraindications such as refractory status epilepticus, there is life-threatening arrhythmias, or a recent cardiac arrest, or a sepsis, or a respiratory distress, or an autonomic instability. If these are all not there, then ECT for an inadequate response could be thought about. This is the consensus based on one article, which says there are two ways to handle. One is an antipsychotic monotherapy, which involves initially maybe a peroral haloperidol or risperidone, or moving on to olanzapine quetiapine. That is one way of management. If they have severe agitation, probably rapid tranquilization using initially a lorazepam, which is a benzodiazepine, when compared to an antipsychotic, and use antipsychotic as a second-line agent. So if both things are fails, then if they are severely agitated, then probably ventilatory, mechanical ventilation, along with opioids or benzodiazepines or dexmedetomidine or propofol or ketamine could be one of the options during that. If everything fails and they are fit enough for an ECT, ECT is still an option in an autoimmune encephalitis. But the main treatment looks like the immunotherapy. So the first-line therapies, many of the times, neurologists prefer a high-dose oral or an intravenous steroids for a non-specific immunosuppression, and plasma exchange and IV immunoglobulins are an immediate acting first-line therapy. Among the second line, if there are cyclophosphamide, mycophenolate mofetil, or rituximab, which is an anti-CD20 monoclonal antibody, is often used. So generally, the guidelines, as we said, are the first line are high-dose steroids, intravenous immunoglobulins, plasmapheresis. The second line are rituximab and cyclophosphamide. But if you have to prevent recurrences, then probably gradual tapering methylprednisolone, azathioprine, methotrexate, all are important things to prevent a relapse of autoimmune encephalitis. But also important is looking for the coexisting tumor and then removal of the tumor. So the patient whom we have seen actually improved very well with an ovariectomy when it was done during her when she had an autoimmune encephalitis, and it actually helped in preventing the recurrences. She improved very well with rituximab and IV immunoglobulins. And the antipsychotics was just given during the initial phase. And now she is a person after 9 months of treatment, there were no relapse. And she was actually going on for her. She is an architect by profession. And she has again flown back to Dubai to join her work and is doing well. So looks like a high index of suspicion also helped us to get a neurologist's opinion. And with these first and second line treatments, she's doing much. So to conclude, so NSABs, they are the most prominently researched is NMDAR and VGKC. But the association of serum NSABs with schizophrenia is actually rare. So it is not a frequent thing. So we need not be always thinking about NSABs in all patients who presents with psychosis. But if there is a subacute onset of isolated psychiatric symptoms with any of the red flag signs, then the possibility of an autoimmune psychosis should be considered. Normal MRI doesn't exclude an autoimmune etiology. So sometimes FDG PET and CSF analysis with an autoimmune profile screening will be required. But the confirmatory is basically based on live mammalian cell-based assay, that is especially the CSF sample, not the serum sample. So a high index of suspicion will be required based on subtle atypicality in the psychiatric presentation. If suspected, have a close liaison with the neurologist. Psychopathogenesis is still evolving. We have idea only based on NMDAR hypofunction, but this model may not be able to explain the psychosis, let's say with VGKC antibodies or an intra like WHO and other GAD like of intrasynaptic, intracellular antigens, we don't know. The psychopharmacological management, think about a drug which has the least possibility of causing EPS. ECT can be considered for refractory conditions with high caution. Thank you.
Thank you, sir, for the wonderful presentation, sir. It was totally engaging right from the beginning to the end. Now we'll have few questions in the chat box. We'll have discussions, sir.
Sure.
Meanwhile, I request the chairperson, Dr. Radhika Reddy ma'am, to give her comments.
Yeah. So while listening to Dr. Pradeep, I could recollect one case. I will just like to share with you all people. See, I had a patient, a girl, young girl of 25, I think 24 to 25-year old. So I know her family also. She got married very recently, and it was a happy marriage, and they left to Canada. And after 1 year, they were okay. And after 1 year, she developed all of a sudden whatever the symptoms Dr. Pradeep has described right now. Like she had all acute psychotic episode. And both families were a little apprehensive, and they started thinking about in some other way, like they wanted any problems in the families. Usually, in our, especially in our cultures, a newly married had some problem, we definitely think about having some other clashes in marital life or something like that. And they started attributing all the things in that relationship issues with the extended family also, like in-laws and other things. And after 1 or 2 weeks, they have requested me to actually over phone. I was talking to the girl also, and so I asked her to get all the investigations and all those things. And finally, one day she had a seizure, and she got admitted to the hospital there in Canada, and they tried to rule out all the things, and they started treating her as acute schizophrenic episode only. And later on, still she is having the same symptoms. They admitted her, and with the detailed investigation, they came to know that there is a teratoma, ovarian teratoma. And the surgery was done, and all the symptoms have almost, they came to standstill sort of thing. And she presented with something like a negative schizophrenia, she was dull and she was not talking, something like that. And in this 3-month period, so whatever damage has to happen, that has happened, like both families were in fighting and all. And she was brought to India. And she was shown in Encephalitis also for second opinion and all. And I gave her risperidone, only a very low dose of risperidone, and she was on that for 6 months or so. And now she is absolutely fine, and she's not on any medication. And the second opinion from Encephalitis also, they told her not to take any medication. So this, I remembered that case after your presentation, Dr. Pradeep. So autoimmune encephalitis, of course, particularly in young women. Women are, I don't know whether the women have more prevalence. That part we have to, because the teratomas more commonly we see in ovaries. So women, and when they present with seizures and any dyskinesia, any autonomic symptoms, along with the psychosis part, definitely we have to take care of the other that suspicion also, especially when it is sudden and there is no family history of any other psychiatric illness and all other things. And if there is any supporting autoimmune like Crohn's and all, so we, especially if they don't tell us about Crohn's, it may be like IBS or anxiety, that kind of thing. So usually we miss it, but with careful examination and little watching and suspicious eye on this, definitely we can treat, and the prognosis will be very good if we are in the treatment is in the similar lines. So you should have enlightened more on the immunotherapy also, because we as psychiatrists are not much aware of, because we don't really give this case to neurology also, because we believe that it is a primary psychosis. So the license will definitely help the patient, and also for us also, because if once the case becomes chronic, we may not really help the patient. So that was really a wonderful session, and I congratulate Dr. PRADEEP and also the whole team, Dr. Selvan, for really selecting a good topic, and also a most appropriate person to deal with this topic. Thank you. Thank you.
Thank you, ma'am. We have a question in the chat box, sir. Pradeep, sir.
Yeah.
Quetiapine, a low-potent antipsychotic with least propensity to cause EPS, can be used for control of psychosis. They have a question. They also have asked if there are any studies regarding the same.
Quetiapine is one of the things which have been reported in case report. But really, in this population, we really don't know whether this person is better off with risperidone when compared to quetiapine. Efficacy studies, there is no any comparable studies are there, but whatever wealth of information we have, quetiapine seems to be a logical choice, probably to treat, which has a less propensity for EPS. So as they pointed out, quetiapine, olanzapine, clozapine, though we may not prefer clozapine as the ideal choice immediately, but definitely olanzapine, quetiapine with a very close monitoring for an EPS is one important thing. So this one thing I wanted to also say is about, I was talking about a girl which we were treating. She developed severe EPS even with 1 milligram of risperidone. It was so confusing for us. So we have to stop risperidone. Then when after the diagnosis of an autoimmune encephalitis was made, then we retrospectively thought probably we should have used some other agent. So it actually helped her to reduce the agitation. But many of the times, without a high index of suspicion, we will think and treat like a primary psychotic illness. So many times it is an afterthought we have to think. So if there is an excessive EPS propensity, think about autoimmune pathology. At the same time, like any logically, we shift to a much more EPS friendly drug like quetiapine or olanzapine when there is more with haloperidol and risperidone. So many times we may not be able to diagnose autoimmune psychosis on the first day itself. So it's a process which builds. And we have to select based on their tolerability.
One more thing, when going for quetiapine, we need to be more careful about the cardiac effects, because most of the time in autoimmune encephalitis, you may have the autonomic dysfunction. So again, there would be some confusion. So I would like to go with clozapine only, because many times we treat it as a refractory and thinking about all EPS, and we start clozapine and they respond also. So that is one thing when we have to be more.
Dr. Subhashini has asked about the role of aripiprazole, sir. I think with this, we'll conclude the question also. Please.
It's the same. I think aripiprazole is another option we can think about. But it is more like a trial and error in autoimmune encephalitis related psychosis. So as I said, we may not, the diagnosis of autoimmune is a process. You may not be able to diagnose them on the first day. based on the response, based on evolution of the symptoms, an autoimmune psychosis is thought about, and probably the workup is again done, and then finally that episode is diagnosed as autoimmune psychosis. So whatever antipsychotics we start, we have to be very wary of the tolerability and think this angle.
Yes, sir. Dr. Venkat Lakshmi has asked a question, sir. We'll conclude with the last one, sir. Is CSF analysis confirmatory in subacute presentation when the patient is seen after 3 months? This is her question.
Yeah. I'm not really sure about how long the antibody stays, but the idea of having a CSF antibody is that it suggests that the antibody is generated within the CNS. So that is the reason when compared to serum, the CSF antibody analysis is done. So usually if it is a subacute presentation, many of the times we do this probably after, during the presentation, during the initial 3 months. So many times there is no any follow-up studies which look at antibody titer after immunotherapy. But it will be nice to look in that way. So I have to look back again into the neurology literature, whether really someone has looked into it. The titer 1:10, whether it became 1:1 after immunotherapy will be a good thing to look forward. But I have not looked into those studies as of now.
Okay. Thank you, sir. Thank you for patiently answering all the questions, sir. For the want of time, we'll conclude for the day. Now I request our course director, Dr. Panneerselvan, sir, to give the concluding remarks.
Thank you, Dr. Aswath. Thank you, Dr. Pradeep. You have done a wonderful presentation, also very informative presentations.
Thank you, sir.
As we said that any patient present with a atypical presentation, we should always think of organicity. As you said, we had a similar case. Actually, 3 months back, we had a case. Actually, he's a husband of a physician. He has developed an acute some polymorph symptoms, some aggressive behavior, restlessness, and in between he became very quiet. So he became mute sometimes. He won't talk, he won't respond. With these symptoms, they're being treated by a psychiatrist actually. These symptoms lasted for almost 3 months. Then he was brought to our hospital. Then we prescribed antipsychotic, but not much improvement in behavioral symptoms. Not much improvement. And he has a memory disturbance also. In between, he became confused. He has a problem with memory. Then we have found that it may be we got a neurologist opinion. A neurologist said that maybe, sir, it may be an NMDAR, this encephalitis, he said, autoimmune encephalitis. Then we did a CSF analysis. Then we found that the person was having a NMDAR encephalitis, autoimmune encephalitis, and he was being treated with this steroid and immune boosters. Actually, he has dramatically improved. And the husband is a very close friend of mine. He was a physician. So then similar cases there. One comment about the presentation that clozapine you have to be very cautious because clozapine is a epileptogenic drug. You have to, if you want to start, you should start in a very low dose. That's one thing. Otherwise, very good and fantastic presentation. I do learn many things from you because we have a psychiatric hospital. Though it's a psychiatric hospital, we used to get many cases presented with the atypical symptoms. And we also use a lot of ECT in our hospital. So we have to consider. I think with no pathology, especially for cardiac risk or other thing is there, I think we can consider ECT also for all the treatment phase. Thank you. And I also thank Dr. Radhika Miti madam for sparing her valuable time. Thank you, madam, for accepting to chair the session. Thank you very much. I thank my colleague Dr. Aswath for this conducting these programs, and also I thank all the participants who patiently listening to these things. We have more than 100 participants. They're staying till the end of the session. I see many participants from other states also, from North India, from Kerala. Also many participants I've seen from Andhra Pradesh also. I've seen some people. So I was very happy to see all these things. And the YouTube link will be available with the eastwestpharma. If anybody wants the YouTube link, it will be shared to you. And also, thank you all. With this, I conclude the session with the eastwestpharma vote of thanks.
Thank you, Doctor. eastwestpharma is proud to have organized such a Evolve academic session for our post-graduation psychiatry. And Doctor, we are extending our gratitude to Dr. Pannisalvan sir for organizing and directing the webinar, and giving special thanks to Dr. Radhika Reddy ma'am for spending her wonderful time with our session and chairing the program. And we are extending our heartfelt thanks to Dr. Ashwath Babu sir for moderating the session, and extending our thanks to especially our speaker, Dr. Pradeep Palniappat sir, for sharing his practical experience on autoimmune encephalitis and psychosis in Ambiguous with our postgraduates. Looking forward to the discussion. It will help our PGs to do it better in their exams as well as in their future practice too. Finally, regarding the session video requirement, kindly contact our eastwestpharma team.